Good morning and welcome. It is my pleasure this morning to introduce Dr. Eric Swenson to speak. Dr. Swenson is a professor of medicine in the Division of Pulmonary and Critical Care, as well as a professor of physiology and biophysics at the University of Washington. He serves as the director of the Pulmonary Diagnostic Services at the VA Puget Sound. Dr. Swenson earned his MD at the University of California in San Diego, followed by fellowship in pharmacology and therapeutics at the University of Florida. He went on to complete his internal medicine training at the University of Pennsylvania, fellowship training in pulmonary and critical care here at the University of Washington, and finally, fellowship training in respiratory medicine at Royal Postgraduate Medical School in London, England. Dr. Swenson's achievements in his role as an educator and a medical researcher are numerous. As an educator, he's earned the David J. Pearson Teaching and Mentoring Award, an award bestowed by Pulmonary and Critical Care Fellows to faculty, acknowledging excellence in education. As a scientist pertinent to his presentation today, a portion of his research is focused on adaptation and maladaptation in animals and humans to high-altitude hypoxia. These efforts have led to innumerable publications, book chapters, and speaking engagements, and it's with this background that he comes to us today. On a more personal note, what I recently learned from Dr. Swenson, aside from the dangers of hyperoxia, are that he is a second-generation pulmonary and critical care doctor with his father starting the Pulmonary and Critical Care Division at the University of Florida in Gainesville. And now his son, Kai, I believe, is going on to Pulmonary and Critical Care Fellowship as well. So please join me in welcoming Dr. Swenson, who has descended from the noble peaks of the VA Puget Sound on Beacon Hill to present Bleeding Ponies, Bloated Cattle, and Breathless Mountaineers, Hearts and Lungs Under Duress at High Altitude.
Thank you, Serena. Well, good morning, everyone, and thanks so much for the opportunity to be here, Serena, for that lovely introduction and bringing my son into the picture. It makes me proud. I've been working in high altitude my entire career, and what I'm going to do in the talk here is to discuss, we already have that. My outline will be to discuss these three particular conditions that relate to problems both at the level of the heart and lungs during exercise and at high altitude, and then bring in some relevance to these conditions as they relate to more standard critical care, cardiopulmonary medicine. And I hope also to bring in some interesting history of the American West, since these three diseases have elements of things that have happened in our western mountainous regions that make for some interesting tales. So the first is this question: why are the banks of the Belle Fourche River red? My son and I were traveling through Wyoming a number of years ago, getting him to college on the East Coast, and we stopped in the Devil's Tower area, and I was speaking with one of the rangers there just about how lovely the banks of the rivers are in that part of the state. And he told me that there's a Cheyenne Indian legend that there was an epic race between the Poe and the Crony, the Crow and the Pony, and that it was a tie, but in keeping up with the Crow, the Pony was coughing up blood and staining the hillsides. Well, this is what we call exercise-induced pulmonary hemorrhage. And it's now very, very much common in the elite thoroughbred horses. Over the several centuries now that thoroughbreds have been bred and continue to be better and better athletes through breeding. Even 300 years ago, and possibly about the same time that the Cheyenne Indians noticed this, they knew that their best horses were bleeding with winning the race. And this one horse here, picture here, was born about 1716, bleeding Chilvers. And so this is alveolar hemorrhage occurring in these very, very fit horses. And they can often present with bleeding through their nostrils or coughing up blood. When when bronchoscopes are put down, you can see the blood originating out of the lungs. And in the few that have been autopsied, you can get a sense here in the dorsal regions, this sort of purplish color of chronic bleeding episodes. They tend to do this more in the dorsal regions. This is where there just is more blood flow rather than in the more ventral regions. And lavage fluid shows you lots of red cells here. So they're bleeding out of the microvasculature of the lung, and I'll explain why this is happening. really it's the problem of the lung and its dilemma. That is, we have this very lacy alveolar capillary barrier. It's basically just this feathery substance hanging out in the air. And of course, we need to minimize the distance between the capillary blood and the alveolar gas to enhance oxygen and CO2 exchange, and also to ensure that the gases coming in equilibrate fully with alveolar gas before leaving to go to the left side of the circulation. And these capillary transit times, particularly during exercise, can be very fast. The red cells have less than a second, maybe even half or a third of a second to undergo gas exchange. But on the other hand, there has to be some structural integrity. And so there's an attempt to maximize this integrity to prevent fluid leakage and vessel rupture, particularly as cardiac output goes extremely high, as I'll show you, and capillary pressures rise to levels that you would not want to see in yourself. Well, here's what happens when horses exercise. Their oxygen consumption rises almost 40-fold from resting. So 3.5 mils per kilogram per minute up to about 150. And that's shown here on this slide here as the horses are racing progressively faster on a treadmill with a ramp to it. And I show you what the maximum oxygen consumption of the best human athletes, which is not bad given the weight differences. We're about half or maybe 40% of what the best thoroughbred horses can do. And to do this, of course, cardiac output has to rise, and it rises about 12-fold from about 20 liters a minute at rest to about 240. So you can see that these horses really are pushing the cardiovascular limits. And what this does then to, of course, pulmonary artery pressures is that over the rise from rest to max exercise, they increase by about 4-fold from about 25 to 100 millimeters of mercury. That's mean arterial pressure. At the same time, the alveolar, or rather the left atrial pressure or the pulmonary arterial wedge pressure rises about 3-fold from 20 to 60 millimeters of mercury. And as part of their incredible athletic prowess, they have huge spleens which contract with exercise and can auto-transfuse them considerably from a crit of about 40 to 65. And so they're designed to be basically the best athletes you can imagine. Well, at a microscopic level, then, here's the problem. And John West, in a number of experiments back several decades ago, came up with the term capillary stress failure. So if we're looking at a small vessel here, of course, the tension on the vessel wall is a product of the pressure and the radius. This is Laplace, the Laplace equation. And here's just a schematic of this thin barrier, alveolar epithelial cells here, basement membrane with some cellular attachments, extracellular matrix, and a capillary endothelium. And in experiments that John West has done to recreate what's happening in those horses by applying instantaneous very high pressures in rabbit and dog lungs and other mammalian lungs, you can start to see with these high pressures breaks there in the epithelium. And then, frankly, at some point, the breaks are complete, and you can see here a red cell is escaping out of the capillary with this kind of rupture. Well, are there any human thoroughbreds? I sort of alluded to, the athletes like the Tour de France cyclists. But I think that the first of this group is John Colter. Colter was a member of the Corps Discovery, the Lewis and Clark expedition, out to find a route out to the Pacific Ocean through 1803 to 1806. He was known as the fittest and simply the strongest member of that expedition, and often given the heaviest task. Well, he stayed out after the expedition completed. He was doing a lot of fur trapping and new pathfinding across the Rockies, and he was likely the first white man to see the Yellowstone and Jackson Hole. Well, in 1808, he was trapping at about 5,000 feet near the Three Forks of the Missouri. He'd been there with the expedition 3 years earlier and knew the land well, and it was rich in fur-bearing animals like beaver. And this episode was described by Washington Irving in his account of the Astoria expedition, which was a follow-on attempt by John Jacob Astor to set up a fur trading colony on the Oregon coast. And the only Indians that the Lewis and Clark expedition had any quarrels with were the Blackfeet Indians. And in fact, one of the encounters led to the death of a couple of Indians. And so they had a bit of a chip on their shoulder. And so here's Colter back out in their hunting grounds. He was captured along with a companion. His companion was immediately killed. He was stripped naked, asked whether he could run, and he demurred a bit and said, I'm not all that fast. Well, they thought that this would be just a game then, that they would give him a head start and then ultimately dispatch him as well. So he was given a head start, a chance to escape. And he ran naked and barefoot, and you can imagine that he gave it a maximal effort under these circumstances. There'd be no question. I think we all would. And he had hemoptysis at some point during this, almost about a 6-mile attempt to escape these 6 Indians that were racing after him. He managed to outrace all of them except one, and then had to fight that last one and killed him. The story goes on even more, which is recounted in this Colter's Run. He then was barefoot and naked for another 10 days trying to get to some outpost where he could find safety. So do we really have any evidence? I mean, you could argue maybe this was just a bad nosebleed under these circumstances, but I think the circumstances do make for a strong story. Turning to modern day cyclists, which are some of the fittest athletes, as I told you about, a group at San Diego, headed by Sue Hopkins, did a study of these cyclists climbing over about a 7-mile uphill maximum course. And then they did bronchoalveolar lavage on these, and then subjects that hadn't done any exercise, equivalently good athletes. And what they found was that the athletes here had a huge amount of red cells in their lavage fluid with virtually nothing in the lavage of those control subjects. So there is evidence, obviously, that we are thoroughbreds to some extent, and we undergo some of the same pressure problems that I mentioned to you with the horses. Well, let me turn now to another big question. This arose in the late 1800s. Why are cattle dying in the Alpine pastures? As we moved into the Great Plains and then ultimately into the Rockies in the latter half of the 1800s, the ranchers loved these high altitude meadows here up at about 10 to 12,000 feet. This was just wonderful grazing land for cattle. Free, and it's still free because most of this is national forest and government-owned land. So we are still bringing lots of cattle up into areas like South Park in Colorado here. But what they were noticing is that a lot of these cattle were dying. And it was upwards of something like 5 to 10% mortality in these cattle taken up to those pastures. They attempted the same thing in Peru, brought cattle over from Virginia, and their mortality rate was even much higher. These were eastern cows that had no previous experience living even on the Great Plains, which are an altitude of anywhere from 3,000 to 5,000 feet, so a little bit of a hypoxia exposure. Well, anyway, what this is brisket or high mountain disease. It's right heart failure or cor pulmonale in cattle. It's swelling of all the loose tissues, and the reason that it has this name brisket is this is the brisket of the cattle. It's also a choice cut of beef, but this is an area of soft tissue with very little support. Cattle don't get ankle edema. They have very tight collagen structures, so they don't get the ankle edema that we get with volume overload and heart failure. And of course, they get all the things you'd expect with cor pulmonale, even worse. And at autopsy, they are found to have these large, flabby hearts and drastically swollen viscera. Well, it took these two Colorado veterinarians at Colorado State University in the early 1900s to at least begin to have some better understanding of what was happening. And they rightfully termed it the dropsy of high altitudes, dropsy being a term for heart failure that we don't use these days, but the old literature, this was the term. And they noted that when healthy cows came up to greater than about 10,000 feet, this was a big problem. They noticed, though, that if the cows could be brought down to altitude, they would recover. So it wasn't an exaggerably lethal disease. As well as they had data to suggest that effective calves sired by low versus high altitude bulls had a difference in mortality, suggesting a genetic predisposition to this. And doing the good epidemiology, they asked, well, could it be related to something about hay or native grasses at those altitudes that might be toxic? And of course, they couldn't find any evidence for that. And they even looked to see if there might be some infectious agent involved. So they did some plasma transfusions to see if they could transmit the disease. And this ruled out any infection or toxins. Well, the condition, any understanding of it really languished until 1960, when these two famous cardiologists at the University of Colorado, Bob Grover and Jack Reeves, knowing of this, I mean, they were fantastic cardiovascular pulmonary physiologists, and they knew of this problem. They decided to really rigorously study it at this place, Summit Flat Lakes, at about 12,000, almost 13,000 feet in the Rockies, and put together a laboratory, a corral here with, you can see some of the wonderful pictures here. Dr. Grover even had his wife working with him up there for about 6 weeks. And they were doing an incredible range of investigations, including multiple right heart catheterizations, doing angiograms, gas exchange, cardiovascular physiology, pathology. And these two gentlemen remained fast friends for the rest of their lives. Bob Grover's still alive. Jack Reeves died about 5 years ago, but incredibly synergistic group of guys. Anyway, what they found was that this is a problem of very severe hypoxic pulmonary vasoconstriction. That's a term for the pulmonologists in the room that were near and dear about what we call HPV, although I still get ads and requests from vaccine companies that ask if I'm interested in an HPV vaccine. And I said, yes, if you could give me one, I could find some use for it, as I'll hopefully unravel for you. Anyway, they realized and made critical measurements to show that this intense hypoxic vasoconstriction caused right heart failure. And what you see on this graph here over weeks at altitude in that study, those steers that didn't get any problems had only very modest increases in pulmonary artery pressure, as opposed to those that developed Brisket disease. You could see how high their pulmonary artery pressures were going. And when they did angiograms on these two different groups of cattle, you can see those that are developing Brisket disease have a very radically pruned and diminished pulmonary circulation, as opposed to those that were doing well. And when they looked at the right heart enlargement here, this is the ventricular ratio, the right to left ventricular ratio. You can see that the control animals had a typical 0.25 or so ratio, but as the mean pulmonary artery pressures rose in those with Brisket disease, you can see a nice relationship between the pulmonary hypertension and the ultimate strain on the right heart. Let me just divert a little bit to hypoxic pulmonary vasoconstriction. This was first published in 1946, and this is the graph from that paper showing that in a rabbit lung, when you first added carbon dioxide, you saw an increase in pulmonary artery pressure. And then when you withdrew the carbon dioxide and then ventilated with 100% oxygen, the pulmonary artery pressure fell down. But then when they ventilated the lungs with 10% oxygen, you can see the drastic rise in pulmonary artery pressure, the first evidence of this phenomenon. And you can here's some angiograms of that. Here's a control animal and then made hypoxic with 5% oxygen. Now I think you can see the caliber reduction and the pruning of the vasculature under these circumstances. And these two men, I think, beautifully said that what this phenomenon does, it's a physiological process that oxygen calls forth a contraction of the lung vessels, thereby increasing blood flow to better ventilated or aerated areas, which leads to improved utilization of the alveolar gas. Well, we have several functions. I've alluded to one already. There's arguments about whether perhaps HPV in utero is more important because under the circumstances of not having the developing lung be the site of gas exchange and that job being taken over by the placenta. It doesn't make a lot of sense to be pushing a lot of blood flow through these lungs that are trying to grow and won't be able to do any gas exchange. So the arrangements with a patent ductus arteriosus and just the way that the fetal circulation is developed, a lot more blood flow goes to the placenta for gas exchange. And then that flow returns in a favorable fashion more toward the head and the heart to support that growth. But in the adult life, alluding to the original discovery of HPV, this is a very nice description that Rob Glennie has drawn of a 2-unit lung, one that's well ventilated and well perfused, and then here's another region of the lung that's poorly ventilated with a degree of bronchoconstriction here, so that its alveolar PO2 is less than the better ventilated unit. And under these circumstances, when these bloods mix, there's a reduction in the arterial PO2 as it goes to the left heart. But if you vasoconstrict in this region, then there's less of this desaturated blood being admitted to the entirety of the pulmonary blood flow, and that the PO2 coming back to the heart is higher. So I think there's a good reason for why we have it in utero for supporting growth. But in lung disease, it may well be that we, with HPV, probably improve arterial PO2 by 20 to 30% on average. And you could argue that perhaps HPV, a strong HPV response, permitted better survival in our evolutionary years when we suffered from pneumonia, chest injury with lung injury that had no other recourse. And perhaps those with stronger HPV survived the hypoxemia that developed with that. Well, there certainly can be adverse consequences to HPV, and it's under circumstances where either a large fraction of the lung is hypoxic or the entire lung is hypoxic. And I list a number of these things: high altitude, sleep apnea, the hypoventilation syndromes, severe obstructive lung disease, severe restrictive disease can all lead to significant regions of the lung being hypoxic and ultimately being a cause for pulmonary hypertension to develop in these different conditions. Well, what about Brisket disease today? It's still a problem of the ranchers in the Rockies, and there's still about a 10% mortality. And this is upwards of about $150 million in losses to ranchers every year. And if those Brisket cattle can be brought down to sea level or back to lower altitudes like Denver, just simply having the disease devalues their value by about 90%. So there's prevention and treatment. You can identify susceptible cattle by catheterization, and this is a picture of a vet that I know and have worked with on one occasion. He does pulmonary artery catheterizations in cattle, and in there at Fort Collins, where he's based, he has some thresholds for pulmonary artery pressure at the mild hypoxia of Fort Collins, and then he'll just say this cow can go or this cow can't go, and he does pretty well. I think what the residents will enjoy is, can you imagine the jugular in this beast? You don't have to worry, you don't need an ultrasound, you don't need to do anything. And this guy can get a catheter in, make those measurements, and be out in 10 minutes. No gowning, no draping, no informed consent. Because all the ranchers want him to do it. Anyway, he's done over 300,000 of these in his 40-year career. And I tried a couple, and you can do it in 10 minutes. Anyway, there's some genetic identification that's now becoming available involving some alpha-2 HIF variants and some others. But everything is really aimed at decreasing hypoxic pulmonary vascular constriction, either by descent, calcium channel blockers, and the PDE5 inhibitors. I tried to get one of the PDE5 inhibitor companies to think about possibly a depot preparation of one of the drugs, Cialis or Viagra, that the cattle could then just get an injection before going up for the summer. This figure of 150 million didn't interest them at all. They said, we have 2 indications, and one of them brings billions and billions of dollars. So there was no interest in pursuing that as a possibility. Now, are there humans with Brisket disease? We haven't alluded that yet. We're a bit more resistant than cattle, but where this was noticed and termed subacute mountain sickness to contrast with what's called acute mountain sickness, when people immediately go up to altitude and just feel wretched for a few days and then get better. This was noted first in Indian soldiers posted to higher than 6,000 meters on the border with China, and they subsequently have had a number of conflicts at that, and still have lots of troops at that altitude. And many of these young soldiers were basically developing pulmonary, as I described there. Now, when they were brought down, and this was 3 days or so, 5 days after descent back to low altitude, and cath, they showed evidence of pulmonary hypertension. It wasn't very reactive to oxygen. It got a lot worse when they exercised. And then after about 3 months of low altitude, they were fine. And the wedge pressures were okay. There was no evidence that this was left heart failure. And the pulmonary vascular resistance values here in Wood's units were consistent with pulmonary hypertension. They all had dilated right ventricles, and a vast number of them had pericardial effusions, all of which disappeared after 3 months. So this is still a problem for the Chinese, the Indians, and also the Pakistanis, where they post a lot of soldiers to these Himalayan passes at their borders. Well, let me now turn to the third condition, and this is work that I've done quite a bit, condition I've studied quite a bit, as some of you in the audience know. But here's the question, posed by a mother to a physician: why did my son get heart failure? And the story is that on New Year's Eve in 1958, this young man, Alex Drummond, wishing to celebrate his 21st birthday and also New Year's Eve, decided he, with a friend, would ski from Maroon Bells up over Buckskin Pass and then to Snowmass on the other side. And as he approached the pass, he was becoming extremely breathless, coughing, congested, and just basically unable to go on. And an alert, his companion skied back down, alerted physicians in the Aspen area, and Dr. Charles Houston, a family practitioner at that time, a well-known mountaineer, put together a team to get him back down, and did, and Alex was fine. But for the mothers in the room, I found this delightful here. This mother asked Dr. Houston, who thought initially the boy had heart failure. And she said, knowing how much he's exerted himself over years, I can't help feeling the explanation must be in the sudden change from mild sea level climate to cold at very high altitudes, plus exertion, actually. These 3 episodes, he had 2 other episodes, not as severe as this one, but she recalled that he complained of some of those same features. She said that it couldn't be coincidence. And then later on, she says, why hasn't he suffered this heart failure while climbing high altitudes at other times, or having already been up at modest to high altitude for a period of time? And in this several sentences, she nailed everything about this condition. And we haven't really altered the important risk factors. She got them all. Well, what this did, high altitude pulmonary edema. And here's a typical X-ray on the left side here. You can see patchy alveolar infiltrates in regions of the lung, often more predominantly early on in the right middle lobe. Here's a CT scan of another patient with high altitude pulmonary edema. And first of all, I think you can see that this doesn't look like left heart failure pulmonary edema, which tends to be more a bat wing, more diffuse pattern, more centrally located. It is nodular, and I'll get to why the appearance of HAPE by CT scanning might look like this. Well, we've known about HAPE for a long time. It's been described in all the earliest records of humans being at high altitude, and variably thought to be either severe bronchitis, pneumonia, or classic left heart failure. And like any pulmonary edema, except for the fact that it's being at altitude, many of these people have this condition of acute mountain sickness initially. It's dyspnea that's first with exertion, progressing to rest, cough, reduced exercise tolerance, ultimately coughing up blood-tinged sputum, crackles on auscultation, and severe cyanosis and oxygen desaturation. Its incidence varies widely with altitude, ascent rate, and some susceptibility factors that I'll go into. So that if you look overall, people are at risk at a rate of about 1 to 15%, depending on the conditions and the speed of ascent. But those people that have had previous episodes of HAPE, under those same circumstances, have about a 60% chance of developing HAPE again. So there is some structural or genetic, physiologic predisposition. Now, HAPE was recognized as a new entity in 1960. I've already alluded to Houston, who was the one who led the rescue of Alex Drummond, and then did further studies in the journal in September of 1960. It was a single case. He initially thought it was left heart failure. Over the next couple of years, a lot of work with other cardiologists showed that this young man didn't have any left ventricular disease at all. It all matters what you publish, because another superb cardiologist, Herb Holmgren in Stanford, who went on after this to do some seminal studies in cardiac catheterization and cabbage surgery, some big VA studies that he headed up. He had been in Peru for a couple of years already, and he knew that the physicians high in the Andes were seeing something like this before. And he published over 20 cases of HAPE in the 59 year in the Stanford Medical Bulletin. So in the days before any kind of online quick access to literature, you can see why Charlie Houston's paper is the one that's most cited. But in fact, Holmgren had done quite a bit of work ahead of time. And what we know about HAPE is that it is truly a hemodynamic problem, but at the same time, there's been some competing or parallel theories about what leads to HAPE. And the hemodynamic theory is that the pressures are so high in the pulmonary capillaries that they leak under high pressure. This would be almost like the stress failure that I mentioned to you with the exercise-induced pulmonary hypertension or hemorrhage. But a lot of studies suggested that there might be an inflammatory component, and this might be a more typical change in the permeability characteristics that happen with infection and inflammation in the lung. And then some other work about a defective degree of active salt water uptake by the lung, which I don't have time enough to go into, but the data here are quite a bit weaker than these two. Well, what we know from the hemodynamics of HAPE is that catheterization studies under a whole series of circumstances, whether they have HAPE at the moment they're catheterized, whether they're catheterized after HAPE, or if they've had HAPE susceptibility and are catheterized and measured while they're hypoxic, what we see is that there's always high pulmonary artery pressures and normal wedge pressures. And the mean pulmonary artery pressures, depending on the circumstances, can range from 40 to 100 millimeters of mercury. These elevated PA pressures always precede the onset of HAPE, so it's not a consequence of HAPE. And HAPE is treated and prevented with any drugs or maneuvers that lower pulmonary artery pressure and hypoxic pulmonary vasoconstriction. And I'm going to talk a little bit about these individuals that are HAPE susceptible because we've studied them on a number of occasions and they've revealed to us quite a bit of understanding of what's going on. This was a study done by a good colleague and friend of mine in Switzerland, Marco Maggiarini, with a number of other colleagues. They took a number of these HAPE-susceptible subjects, had them climb to this mountain hut at about 15,000 feet on the Swiss-Italian border called the Capanna Margherita. And you can see here's a picture of that hut. It's 3 stories. It's been there in various forms since the late 1880s and named after Queen Margherita of Italy at the time. And what they did was they did pulmonary artery catheterizations on these climbers as they came to the hut after a little bit of wine and a little bit of rest. And they catheterized them at sea level, and they had these groups, the control groups that had never had HAPE, and then the HAPE susceptible groups, and then they divided them into those subjects that were HAPE susceptible that actually got HAPE while they were there at high altitude. And when you look at the pulmonary artery pressures, you can see that these HAPE susceptibles have higher pulmonary artery pressures, and those that were developing HAPE had the highest. They also made an attempt at measuring the pulmonary capillary wedge pressure. When they did the capillary pressure, not the left atrial pressure, because they could wedge and show that there was no elevation in the wedge pressure. But you can take the catheterization data and manipulate it a bit to try to estimate what the true capillary pressure is. And when they did that, they showed that all of those developing HAPE had 20 millimeters of mercury higher. So a pressure at the capillary level high enough to cause leakage. And a lot of animal work suggests that 20 millimeters of mercury acutely is a threshold for capillaries, pulmonary capillaries to leak. Well, these HAPE-susceptible subjects, which have been wonderful to study, and it's been interesting that they are often very keen to be studied because they want to know what's going on with something that they love to do and has in some cases threatened their lives. We know that they have very high hypoxic and exercise or a stress-related increase in pulmonary artery pressure, and they have greater sympathetic nervous system activation. Interestingly, they have slightly smaller lungs for the same body size and less diffusing capacity, particularly as it's recruited with exercise and hypoxia. They also are not blessed with a strong ventilatory response to hypoxia, so they breathe less than the average person. This leads to a relative hypoventilation at high altitude. And some studies I've done with Tyler Albert, we've shown that there's possibly reduced chemosensitivity augments hypoxic pulmonary vasoconstriction. And there's a smaller diuretic response in these people to hypoxia. So the three things you don't want to do at high altitude is constrict your pulmonary vessels. You don't want to not breathe as much as your companions, and you likely want to diurese more to almost anticipate an edematous-like problem. Well, here's some data with colleagues in Heidelberg when I was on sabbatical. We looked at a group that were HAPE susceptible. These are the dotted lines here, breathing 12% oxygen and looking at the pulmonary artery pressure estimated by echo. And you can see that those HAPE susceptibles have much stronger pulmonary vascular responses. And interestingly, when they exercise at sea level, i.e. not hypoxic, but just heavy exercise at about 240 watts, you can see those that are HAPE susceptible have only a modest rise in pulmonary artery pressure. But these equally fit people that are HAPE susceptible had incredibly high increases in pulmonary artery pressure. And Herb Holkren had similar data here in these HAPE susceptibles. Here he's measuring cardiac output as a function of their exercise. And here's a control group, and here are the HAPE susceptible groups with these incredible rises in pulmonary pressure. Now, this whole phenomenon, this exaggerated HPV, kind of begs a question that's out there in the pulmonary field, is that we talk sometimes about an out of proportion pulmonary hypertension that develops in a number of conditions, whether it's COPD, congestive heart failure, obstructive sleep apnea, or interstitial lung disease. You wonder whether with this genetic predisposition, then if you get another condition later in your life that leads to problems with alveolar hypoxia, you have a stronger HPV and it ultimately leads to more pulmonary hypertension. Well, this was studied and these are some incident figures of the rate at which there may be out of proportion pulmonary hypertension in these different conditions. A big study done in Germany looked at controls and healthy relatives of patients with pulmonary arterial hypertension, most of them with this BMPR2 mutant. And the SIBs and relatives didn't have that. And what they looked at was at rest in normoxia, the distribution between those relatives of the people with pulmonary artery hypertension was the same in terms of the right ventricular ejection fraction velocity that's measured by echo. But when they made them either exercise and did echoes, you can see that these relatives, there was a proportion of them that seemed to have brisker pulmonary vascular pressure increases. And as well, when they subjected these same subjects to hypoxia, you can see that there's a greater degree of excessive vasoconstriction or hypertension in those groups. So it may well be that among you in this room, there are some of you that, since you've never gone to high altitude or done this, you may be sitting on this sort of exuberant pulmonary circulation that might be a little bit more activated by stresses. Well, you might ask, hypoxic pulmonary vasoconstriction, which is constriction at the arteriolar level, lead to edema at the capillary level. You would think that if the resistance were upstream of the capillaries would be protected from this. And again, this is work and theory of Herb Holkren, who has postulated, and we still don't have definitive evidence for it, but I think it's a compelling theory, and I'll show you indirect evidence for it. But he proposed that if you look across the lung, there are some regions of the lung that probably have very weak HPV, and there are some that constrict considerably with the same degree of hypoxia. This leads then to, as all areas are variably constricting, an upstream elevation in pulmonary artery pressure. And in those areas that simply don't have much in the way of vasoconstriction, those are the areas that are going to have a higher blood flow at higher pressure and ultimately reach a capillary pressure high enough to cause leakage, which is occurring right here. So I think this is the explanation for why we see this patchiness of the edema formation. These must be the areas that probably have lesser HPV, and so are the areas that are undergoing leak. Now, there's also possibly an element of venoconstriction that complicates this picture as well. But he termed this business overperfusion edema. That is, that there is some point at which lung simply can't bear a certain amount of cardiac output at a certain pressure before it fails. Capillary stress failure that I mentioned. Well, two studies have looked at this in these HAPE-susceptible subjects by putting them in the MR scanner and then making them hypoxic and then looking at the regional dispersion of blood flow and then looking at what happens when hypoxia is introduced, having these subjects breathe 10 to 12% oxygen. And this study here, starting with a control relative dispersion of pulmonary blood flow throughout the lung of about 0.95, those HAPE-susceptible subjects with even 20 or 30 minutes of hypoxia are already showing a dispersion of blood flows suggestive of possibly some unevenness in hypoxic pulmonary vasoconstriction. Sue Hopkins, who I mentioned already, had two other groups here, those with no altitude history whatsoever and those with a history of HAPE resistant. And these two groups didn't show this phenomena of worsening diversion or dispersion of pulmonary blood flow. Well, Herb Hopen was the one to put together this idea. What he did in a dog lung was perfuse the lungs with 1 liter a minute, average for a dog of the size that he was looking at, and then just did progressive lobectomies, and look what happened to the lung. And ultimately, when only the left upper lobe was remaining, then the lung began to gain weight. It was engorged. There was evidence of hemorrhagic edema and a fluid with a high protein content. So it may well be that lungs, either in general, can only bear about a 6-fold increase in their total blood flow without having problems, or some region of lung that has to bear greater than 6 times its maximal amount of blood flow will undergo this phenomenon of overperfusion pulmonary edema. Now, we probably see overperfusion edema in a lot of situations clinically. We've already mentioned the elite athletes. This may well be a problem in patients receiving lung transplants in their first days. These are lungs that have been in a bucket and cold for a while and simply are not ready to receive an entire cardiac output. And so there can be pulmonary edema and what we call acute graft dysfunction. It can happen after post-pneumonectomy. It can happen with severe pulmonary embolism. And I show you two radiographs here. One is just a plain X-ray, and I'm sorry, a little bit more light here, but I think you can see areas of edema in the lower lobe, some areas of edema in the left upper lobe. And you can see that in this case of severe embolism, it's only those two areas of the lung, left lower lobe, left upper, and even some in the right lower lobe. Those are the only areas being perfused, and that's where the edema is developing. This can happen after post-arterial lysis, correction of intra-arterial shunts, pulmonary edema, and then a condition that some swimmers have, which is called emergent pulmonary edema. Well, I've already alluded to this idea of capillary stress failure occurring at these very, very high pressures that just exceed the load-bearing capacity of the collagen and extracellular matrix, leading to trauma and then ultimately alveolar hemorrhage here. But probably at a lesser rise in pulmonary artery pressures and flow, there's some dynamic changes in the permeability of the pulmonary circulation that involve either fluid crossing into the lung paracellularly, that is between cells, with discontinuities in cell-to-cell contacts that allow more fluid, but also possibly increased transcellular flow through vesicular flow through the cell itself that causes maybe some of the milder forms of high-altitude pulmonary edema. If you were to look at just basically a relationship between lung water and microvascular pressure, at low microvascular pressures, we all have some fluid leaving our circulation and being cleared by the lymphatic system in a normal X-ray, but as we increase flux with higher pressures, there's inability to handle that by the lymphatic drainage. We get interstitial edema. But ultimately, when we get to very high pressures, you have this hemorrhage, and I'll talk a little bit about some secondary inflammation. This leads then to this idea of inflammatory theory of HAPE, which arose out of a number of studies, but just simply the issue of inflammation and inflammatory mediators, pro-inflammatory cytokines, leading to disruptions and irregularities of the normal permeability of the lung microvasculature. And a lot of studies pointed to this. Some early bronchoalveolar lavage studies that I'll talk about that I was involved with as well, and some studies in Japan, showed that there was inflammation in the lavage fluid, but these were patients that had been ill for several days with their HAPE. And animal studies trying to mimic this by giving virus or endotoxin, you could get a HAPE-like condition in these animals. And interestingly, the most potent anti-inflammatory agent would prevent this. And then in cell studies, if you take leukocytes and endothelial cells and make them severely hypoxic, many of them will release pro-inflammatory cytokines. So there's a background for the idea that there might be inflammation. And this man, many of you in the audience that are of an older generation, is Bob Shaney. He was on the faculty here in our division. In the mid-1980s, went up one summer to do bronchoscopies on subjects developing HAPE as they were trying to climb Mount Denali or Mount McKinley. How he ever got this through human subjects in today was remarkable, because these are not all that sterile conditions, and you can wonder whether someone who's hypoxemic at a stat of 50 can give informed consent, but we did get it in those days. And in the second summer, I joined Brownie. That's how I got into this whole business. He said, after finishing my fellowship year, he said, "Do you want to come up and work with us in Alaska?" And I said, "Sure." So I did a number of those bronchoscopies as well. But what in these several summers worth of work we found was that if you looked at the lavage proteins in patients with HAPE, it was an incredible proteinaceous lavage. And in fact, in reference to ARDS, which we think is the prototypical worst permeability characteristics of the lung, these HAPE subjects had even higher proteins. This was some work that Tom Martin was seminal in providing us the data for and doing the measurements. People with AMS just feeling a little lousy at altitude had no difference. And I just give you the values in those that are sea level typical normal values, and those that were at high altitude without any evidence of HAPE. And when we looked at the lavage characteristics of white cells, neutrophils, here are the normal values, and you can see in many of these HAPE subjects evidence of some considerable inflammation by these different markers. Well, is inflammation causal in HAPE? That was the question. And 10 years after doing that study with Brownie up in Alaska, after taking a year sabbatical in Germany with one of the best altitude researchers there at Heidelberg and with colleagues at Zurich, we decided to recruit HAPE-susceptible subjects that had gotten HAPE at this same mountain hut, the Capana Margarita that I mentioned before, and would they come up and risk getting HAPE under conditions that were clearly far safer, because we had oxygen, we had all the medicines, we had, in fact, easy evacuation if necessary. And so we did a number of studies in Zurich on all these subjects before they climbed, and then they climbed over 2 days to the summit of this mountain. This is a very popular route here. On a weekend, you can see about half the population of northern Italy is on its way up, just to have some wine at the summit and then get back to work the next day. Anyway, we did a huge number of studies, including the bronchoscopies, as well as echoes to make pulmonary artery pressure measurements. And so bringing the bronchoscope back up to high altitude here, here's one of our subjects that developed very early HAPE on the very first day, and that was our intent, to try to make these measurements early. And so here I am doing a bronchoscopy on one of these subjects, and here's the lavage fluid, which I think you can already see is somewhat bloody. And what we found in breaking up our subjects, like I showed you in the other study, that catheterization study of those HAPE susceptible that developed HAPE while they were there and those that didn't, when we looked at their pulmonary artery pressures by echo at sea level, there was really no distinguishing difference. The control group had only a modest rise in pulmonary artery pressure. The group that was susceptible, that didn't get HAPE on that occasion, had higher increases, but those that had HAPE had the highest. And then when we graphed the PA systolic pressures against either the amount of red cells in their lavage fluid or the albumin as another marker of leak, I think you can see a dose response here of the higher the pressure, the greater the escape of these markers of alveolar capillary leak. Now, that certainly established that this is a hemodynamic problem. But in doing the lavages of those subjects, again, here are the data from early studies that I include both the Denali studies that I mentioned, as well as some Japanese studies. And you can see here that these are the late studies, I'm sorry, these are the patients that had HAPE for several days or more. Here are the data from the early studies that we did, and there was really no convincing evidence of any inflammation under those circumstances. The white cell count was trivial, there's very little in the way of any pro-inflammatory response. So we think that this inflammation in HAPE is probably a secondary phenomenon, that once the lung is injured, perhaps this is just a stereotypical response to tissue injury, that inflammation, leukocytes are drawn into sites of injury to be part of the repair. Well, how can you prevent HAPE? Well, certainly if you have had it before, you know you're susceptible, and therefore past history is most productive. It would be interesting to think that you could test for hypoxic pulmonary vasoconstriction like that veterinarian in Colorado does with the cows, but the data are not convincing enough to suggest that we have enough selectivity and sensitivity, specificity, sensitivity to make it worthwhile. It's an expensive test, even if it's non-invasive with echo. Non-pharmacologically, you can, of course, try to ascend a bit slower, and this is a fairly safe rate of ascent, and then rest every several days. Take your time, enjoy the environment, and sleep as low as possible on your route. And then there's some pharmacologic studies that have been done looking at these HAPE susceptibles and randomly assigning them to either calcium channel blockers or inhaled salmeterol. Beta agonists sometimes reduce pulmonary pressures. Here's the PDE5 inhibitor, tadalafil. And depending on the circumstances, you get about anywhere from a 50 to a 90% reduction. Interesting, dexamethasone, which we wouldn't think had any pulmonary vascular effects, was 100% effective. And it turns out now that dexamethasone, if given for several days before going to altitude, stimulates endothelial nitric oxide synthase, NO production. So it's not something that happens immediately to use as treatment, but for prevention, you could take dexamethasone several days beforehand. And a drug that I've been interested in all my career, acetazolamide, a prototypical carbonic anhydrase inhibitor, reduces pulmonary vascular hypoxic vasoconstriction considerably. These are some original studies we did in a dog where we made the dogs hypoxic with 10 or 12% oxygen, and you can see the immediate rise in pulmonary artery pressure that was blunted when we gave Diamox under 2 different drug regimens. Data in humans using echo show the same phenomenon, that here's the normal rise in pulmonary artery pressure with no drug, and then pretreatment with acetazolamide virtually abolished the rise in pulmonary artery pressure. At altitude, with a group in China, we looked at people flying to 3,800 meters and then monitoring their pulmonary artery pressures once they arrived. And here are the data for the Diamox pretreatment against a control group and another drug that was thought to possibly be beneficial at high altitude, but in this case was not. And when we looked at the arterial saturations, those that were on Diamox had a higher saturation as well. So there was a 2+ consequence, better saturation as well as reduced pulmonary artery pressures. So what we are doing this summer then is to test Diamox as a preventative for HAPE at that same Campana Margherita on the Swiss-Italian border, recruiting these HAPE-susceptible subjects and randomly assigning them to Diamox or not. So let me end here then with sort of this global overview here of the threat of pulmonary hypertension, particularly as it relates to exercise and hypoxia, leading to high flow, and in many cases with hypoxic pulmonary vasoconstriction as element, leading to these elevations in pulmonary and capillary pressures, which in horses leads to exercise-induced pulmonary hemorrhage. In cattle, cause Brisket disease. And humans, I've shown you data to suggest that all 3 of these conditions happen depending on the circumstances. There haven't been cases of HAPE in either of these 2 species as far as I know, but we get all 3. So in ending, what lessons can we take from these diseases on high? It's to understand that healthy lungs and hearts can fail under the extremes of the highest blood flows and pressures that you might put your heart and lungs under, particularly with heaviest exercise and high altitude. And that at some point, these high lung blood flows and microvascular pressures exceed the ability of the lung simply to maintain adequate fluid balance and in capillary integrity, this idea of overperfusion edema, that may lead ultimately to some degree of overperfusion injury, as we've talked about. And that this HAPE susceptibility might be a form thrust of this phenomenon of out of proportion pulmonary hypertension that develops in patients with diffuse long-standing lung diseases. And that excessive hypoxic pulmonary vasoconstriction can lead to immediate or more chronic right heart failure. So let me end here with some thanks and acknowledgments. I've had fantastic friendships and collaborations and mentoring from a broad number of people, some of them in the room here. Bob Shaney, I've already alluded to, Tom Hornbein, Tom Robertson in our division. I've alluded to Tom Martin's important as well, Rick Albert, Steve Dean, Andy Lux, and even in terms of a generational tradition, his father, Rick Albert, sired Tyler Albert, and Tyler's with us here these days. And a group of fantastic European and other North American colleagues that have just made this a wonderful area to work in. And, you know, these people range from mentors to colleagues to co-workers, co-authors, and friends. And ultimately, over the years, they seem to all just merge into one. So thank you very much.
Eric, thank you for that great talk. Is the pathophysiology that you described for high altitude pulmonary edema similar to what we think is going on with high altitude cerebral edema? And what do we know about whether susceptibility to the syndromes you described predicts susceptibility to any of the CNS kinds of manifestations of high altitude sickness?
You pose some very, very interesting questions that sort of bedevil us. Unfortunately, high altitude cerebral edema is very rare and often quickly lethal. So we haven't been able to do these kind of studies. It would be hard to recruit people with previous HACE, as we term it. Certainly what's happening in HACE, I think the evidence from imaging and some animal studies suggests that with severe enough hypoxia, the brain circulation and the entire CNS struggles with hypoxia, and there's breakdown of not only vascular barriers, but there's also probably some neuronal cytotoxicity that develops, so leading to both what we call vasogenic edema as well as cytotoxic or intracellular edema. There's not too much link between high altitude pulmonary edema and high altitude cerebral edema, except that if you get high altitude pulmonary edema and become very hypoxemic, that may be a trigger for ultimate development of HACE. But I don't think that they're linked in any way that we've been able to discover, either at a genetic level or other possibilities. But it's certainly an interesting thought.
Yes, the data you showed about pulmonary artery hypertension in some patients or some subjects at normal levels of oxygen raises the question of whether some patients who are diagnosed as exercise-induced asthma actually have pulmonary artery hypertension as a mechanism. Is that known, or has that been looked at?
The question for those that might not have heard it is could this phenomenon of exercise-induced asthma, which is fairly prevalent at maybe 5% of particularly the best athletes, could this be related to hypoxic pulmonary vasoconstriction, or not, or rather just a reactive pulmonary circulation to the stress of exercise, even if it's normoxic? No one's looked into it. We certainly know that there's no evidence of airway bronchoconstriction in HAPE, as opposed to the definite measurements of bronchoconstriction in those with exercise-induced asthma. But that doesn't mean that they might not have some element of increased pulmonary vascular pressures as well, perhaps maybe increasing the sensitivity of their airways to the stress of hyperventilation, cold air, and high levels of ventilation.
Eric, thanks for a very wonderful talk. You had HIF, hypoxia-inducible factor, on some of your slides, and I'm wondering, are there any differences in either basal or induced upregulated levels of HIF in susceptible versus non-susceptible individuals?
What Jeff is alluding to is an important transcription factor called hypoxia-inducible factor. It seems to be upregulated in every cell as soon as it becomes hypoxic, and there's several isoforms of it, 1, 2, and even 3. I don't know that there have been studies to show that there's a biologic variability in terms of how cells from individual to individual differ in that regard. But there certainly is the thought that HIF-1 in particular, but even HIF-2, may be involved in stronger pulmonary vascular responses. And so down the road, as we get specific HIF inhibitors, which will probably make a big entrance into cancer chemotherapy at some point, we may be able to begin to get questions of pulmonary vasoconstriction and pulmonary hypertension with HIF-related pathways.